Let us acknowledge the Lord. Let us press on to acknowledge him. As surely as the sun rises, he will appear. He will come to us like the winter rains, like the spring rains that water the earth. Amen. So now we're going to start with the coagulative necrosis. Coagulative necrosis, and this is necrotic tissue that remains firm. The cell shape and organ structure are preserved by coagulation of proteins, but the nucleus disappears. Characteristic of ischemic infarction of any organ except the brain. Area of infarcted tissue is often wedge-shaped, pointing to focus of vascular occlusion and pale. Red infarction arises if blood re-enters a loosely organized tissue, like in pulmonary or testicular infarction. Okay, so what this means is, in coagulative necrosis, cells coagulate so tissue retains the shape, but the nucleus disappears. And every organ in the body that undergoes ischemic infarction, will exhibit coagulative necrosis except the brain, and the brain we'll get to later. So think of any organ that undergoes ischemia, you're going to see coagulative necrosis, which is when the shape remains, but the nucleus of like the shape of the tissue remains, but the nucleus disappears. Um, and area of infarcted tissue is often wedge-shaped, pointing to focus of vascular occlusion. So that's this. Okay, let's see. So right here, this is an example of coagulative necrosis of the kidney. Okay, you see this right here? This right here is the coagulative necrosis. Um, it'll be white. Going to focus of vascular occlusion and pale, right? So it's going to the area of coagulative necrosis will be white, as you see here. So this right here is showing the picture, close up of the picture. So basically, the kidney is a solid organ, single blood supply. So let's say there is a occlusion in the renal artery, right? Let's say let's say this is a renal artery, and then the occlusion is right here. So there's no blood flow going to this area. So this area is going to be white, which is what we see here. This is the area of infarct. Okay, so that's that. Okay, so next. Oops. A red infarction arises if blood re-enters a loosely organized tissue. Pulmonary or testicular infarction. Let's look it up. Pulmonary or testicular infarction. Pulmonary infarction. Coagulative necrosis. Okay. Okay, so function. So this is coagulative necrosis. Um, You can't see the nucleus, right? See all this area, the nucleus is missing. That's a typical feature of coagulative necrosis. I'm trying to figure out what red infarction is. So, red infarcts are exactly what they sound like. They're red areas in organs. Basically, this is white, like we just saw in the kidney. This is a white infarct. This is a red infarct. 1, 2, 3. So, if you want to see another picture, it'll be this. See this? This area is a red infarct. And this is what it looks like close up. As you can see, it's more dense in color. And also, I can't see any nucleus. So, yeah. So this is coagulative necrosis. When infarcts occur in organs with dual blood supply, like the lungs. So, yeah, like the lungs and the heart. You can get a red infarct. Okay. Brain infarction arises if blood re-enters a loosely organized tissue like the lungs or the testicle. Okay. Next we have liquefactive necrosis. This is necrotic tissue that becomes liquefied. Enzymatic lysis of cells and protein results in liquefaction, characteristic of brain infarction. Proteolytic enzymes from the microglial cells liquefy the brain. Abscess, proteolytic enzymes from neutrophils liquefy tissue. Pancreatitis, proteolytic enzymes from the pancreas liquefy the parenchyma of the pancreas. So, what this means is, in liquefactive necrosis, the enzymatic lysis, there's enzymatic lysis of cells and proteins in the brain. So, characteristic of brain infarction. So, the microglial cells have proteolytic enzymes in them that destroy the brain. And microglial cells are the macrophages of the brain. Okay, so they have the ability to destroy the brain. Abscess. So an abscess can get liquefactive necrosis because the neutrophils have hydrolytic enzymes, and these hydrolytic enzymes destroy tissue. Okay, next. Uh, Also in the pancreas, you can get liquefaction necrosis because enzymes from the pancreas digest pancreatic parenchyma. Okay, so next we have gangrenous necrosis. This is coagulative necrosis that resembles mummified tissue. Okay, and gangrenous necrosis is characteristic of ischemia of the lower limbs and the gastrointestinal tract. Gangrenous necrosis, if superimposed infection, uh, if superimposed infection of dead tissue occurs, then liquefactive necrosis ensues. Okay, so in gangrenous necrosis, it looks like it's a it's a coagulative it's a type of coagulative necrosis, which means that you can't see the nucleus, um, but the shape still remains. But in gangrenous necrosis, it looks like mummified tissue. This one right here. This. So, this second picture of the mummy-like foot. So that would be gangrenous necrosis, specifically dry gangrene, ischemia of the characteristic of ischemia of lower limb and GI tract. So if somebody has diabetes, that would be gangrene. That can turn in, like, if it's not taken care of, it can turn into gangrenous necrosis. So ischemia of the lower limb, because in diabetes you don't get proper blood flow to your legs, and over time, if you don't, if it's not taken care of, if your blood sugar is not controlled, you have eventually you can get gangrenous necrosis, and you have to amputate the foot. Okay, I'll show you. So a lot of these, they won't show you, but trying to find a picture. Hold on. So here it is. So this is a picture of gangrene, healthy tissue, gangrenous tissue. Okay. Okay. Well, that's. So you have an idea what this is. Okay. So here the second toe was amputated. Okay. If superimposed infection of dead tissue occurs, then you can get liquefactive necrosis also. Like, that would be wet gangrene. So if you have an infection, and if you have an infection that turns into gangrene, you can also get liquefactive necrosis. Okay, let's see. Okay. This is what it is. So wet gangrene would look like this. It's more liquidy slash wet, and it has, bubbles. It would look like bubbles underneath the skin. But dry gangrene, it looks like almost mummified. Some of these pictures, like, I can't even look at. I don't know. I know. I'm supposed to be doctors or almost doctors, but nope. So yeah, you see how these are like dry, very very dry. There's no bubbles. There's no wetness. Okay. So what I want you to know is, gangrenous necrosis can turn into the liquefactive, could turn into liquefactive necrosis, and it would be wet, like we just saw. The reason I'm showing you pictures is so neither you nor I will forget. Okay, cautious necrosis. Cautious necrosis is soft and friable necrotic tissue with cottage cheese-like appearance. Right here. That was like cottage cheese, right? How do you like cottage cheese? Maybe that's one of the reasons. When I first saw this, I was like, nope, it looks like cottage cheese. And I never had cottage cheese. I don't think I ever had cottage cheese. But yeah, so this cautious necrosis combination of coagulative and liquefactive necrosis, which means that you can't see the nucleus because it's coagulative, and liquefactive necrosis because it'll be mushy because of all the enzymatic destruction. So it's like a combination of both. It's like mushy substance with no nucleus, and it's not firm either. Like because so coagulative necrosis would have no nucleus, and liquefactive necrosis, I think, a mush because of all the destruction of the enzymes. So a mush with no nucleus. That'll be cautious necrosis. Soft necrotic tissue with cottage cheese-like appearance. If you don't know what cottage cheese looks like, this is cottage cheese. Right? Yes. Okay, so cottage cheese right there. So cautious necrosis. This is characteristic of granulomatosis inflammation due to tuberculosis or fungal infection. Cautious necrosis. Yeah, it's characteristic of granulomatous inflammation due to tuberculosis or fungal infection. Okay. So in tuberculosis and fungal infections, you would see cautious necrosis because you would see granulomatosis inflammation in both fungal and tuberculosis. So both of those would result in cautious necrosis. And this right here is of the lung. Down here, this is cautious necrosis of the lung. This is dry gangrene, and this right here is a testicle. So you can see the venous supply is blocked off, and then the artery is still open. So the red infarction arises if blood re-enters, right? Re-enters a loosely organized tissue like the testicle. Okay. So the testicle, lungs, and the heart both have, all of them have the dual blood supply, and that's where we kind of see infarction more, red infarction more, because blood can come back in after, blood can come back in after infarction. Because it has two supplies, so if one is cut off, the other one can enter, and that's why it's red. Okay, next. Step. Okay, fat necrosis. Fat necrosis is necrotic adipose tissue with chalky white appearance due to deposition of calcium. Characteristic of trauma to fat, like in breast tissue, and pancreatitis mediated damage of peripancreatic fat. Fatty acids released by trauma, like in the breast, or lipase, like in pancreatitis, join with calcium by a process called saponification. Saponification is an example of dystrophic calcification, in which calcium deposits on dead tissues. In dystrophic calcification, the necrotic tissue acts as a nidus for calcification in the setting of normal calcium and phosphate. Metastatic calcification, as opposed to dystrophic calcification, occurs when high serum calcium or phosphate levels lead to calcium deposition in normal tissues, like in hyperparathyroidism, leading to nephrocalcinosis. So here, fat necrosis is when fat dies and fatty acids are released, and these fatty acids bind to the calcium, and this is known as saponification. So, let's say a woman was, she was involved in a car accident, and then she hit her breast on the dashboard, and let's say it was a massive collision, and this is trauma to the breast, and so fatty acids are now released from the breast, and they will join with calcium, right? And this calcium will deposit in this dead tissue in the breast, right? So this is what that looks like. Fat necrosis in the breast. See this white deposition? This is calcium. Okay, so that's that. And there's two types: dystrophic calcification and a metastatic calcification. This has nothing to do with cancer, okay? It's just the name of it. Dystrophic calcification, metastatic uh, calcification. Calcification is when calcium deposits in dead tissues. Um, so the necrotic tissue acts as a nidus for calcification in the setting of normal calcium and phosphate. So there, in dystrophic calcification, the calcium level and phosphate are both normal. Um, Whereas in metastatic calcification, it's going to be high calcium or and high calcium. High calcium or high phosphate levels. And in metastatic calcification, the calcification, like calcium, deposits only in, deposits on normal tissues. And dystrophic calcification, it's only the calcium deposition is in the dead tissues or the necrosis or the tissues that underwent necrosis, like for the breast, right? In a metastatic calcification, the calcium and phosphate levels, one or the other, is high, and the calcium deposits in normal tissues. For example, hyperparathyroidism leading to nephrocalcinosis. So, hyperparathyroidism, that's increased calcium um, in the kidneys. So, hyperparathyroid, parathyroid, there's increased calcium in the from the hyper from the parathyroid, and then that will deposit in the kidneys, causing the nephrocalcinosis. So calcium doesn't normally um, deposit in human tissue, but when it does, it's by either dystrophic calcification or metastatic calcification. We talked about the changes here between the two. Okay. So your body does not make calcium. What you eat, like, it's from milk, cheese, yogurt, um, fortified foods. That's where you get calcium from, and your intestines absorb the calcium from your food, and then vitamin D helps your body absorb calcium more effectively. So your intestines absorb the calcium, then it goes out of your intestines. Your parathyroid hormone senses if it's like calcium is low or high, and in primary hyperparathyroidism, your PTH, which is a parathyroid hormone, is high, which would mean it increases the calcium in your body. And then PTH, whenever PTH is high, phosphate is low. Except for, like rare case, like there's exceptions, but generally when PTH is high, a phosphate is the other way around. Yeah. So if your blood calcium is low, PTH is released. PTH is released to signal the bones to release calcium. So if your calcium is low, PTH will be up. Okay. But here, for like Pathoma, they were talking about hyperparathyroidism leading to nephrocalcinosis. And hyperparathyroidism can happen due to parathyroid adenoma, parathyroid hyperplasia, and even cancer. So you'll have too much PTH, and that will cause too much calcium and decrease phosphate. That's primary hyperparathyroidism. Even if your calcium is low, it can raise the PTH because the PTH is trying to compensate and bring up the calcium. So it's okay. Now we have fibrinoid necrosis. This is necrotic damage to the blood vessel wall, leaking of proteins including fibrin into the vessel, and results in bright pink staining of the wall. Okay. Like this, that's fibrinoid necrosis. Right here. See this? Okay. So that little round that I just showed you, that was a bright pink staining. Of proteins and fibrin leaking into the vessel wall. You can see this fibrinoid necrosis in malignant hypertension and vasculitis. I just think of like the BP is so high that blood vessels pop. Okay, so here you want to know that fat necrosis mainly happens in breast and the pancreas. And then you also want to know pancreatitis has two types of necrosis associated with it, which is liquefactive necrosis and fat necrosis. So the liquefactive necrosis would be of the pancreatic parenchyma, and fat necrosis would be of peripancreatic fat. So pancreatitis has liquefactive necrosis and fat necrosis. And fat necrosis happens in both breast and pancreas. Also, something you want to know, let's say a 30-year-old woman presents with fibrinoid necrosis. Think fibrinoid necrosis is due to preeclampsia, so the patient has fibrinoid necrosis of the placenta. It's a fact aside you want to note down. Because what is preeclampsia? Preeclampsia is a condition that happens during pregnancy, usually after 20 weeks. It causes high blood pressure and signs of damage to other organs such as liver and kidneys. The BP here would be 140 by 90 or higher. You'll see protein in the urine, swelling, and sudden weight gain, and vision changes. And it's serious because of organ damage, placental abruption, and the way to stop this is to deliver the baby. But what we have to know is it causes high BP, and high BP, you want to think of fibrinoid necrosis. See this? Fibrinoid necrosis. Okay. Next we have apoptosis. In apoptosis, there is no inflammation following there is no inflammation after apoptosis happens. But in necrosis, there's always acute inflammation. Apoptosis, energy, ATP, dependent, generally programmed cell death involving single cells or small groups of cells. Examples include endometrial shedding during menstrual cycle, removal of cells during embryogenesis, and the CD8 T cell mediated killing of virally infected cells. Morphology: the dying cell shrinks, leading cytoplasm to become more eosinophilic. Nucleus condenses and fragments in an organized manner. Apoptotic bodies fall from the cell and are removed by macrophages. Apoptosis is not followed by inflammation. Apoptosis is mediated by caspases that activate proteases and endonucleases. Proteases break down the cytoskeleton. Endonucleases break down DNA. Okay, and then caspases are activated by multiple pathways. The first way is intrinsic mitochondrial pathway. And this is when cellular injury and DNA damage or decreased hormonal stimulation leads to inactivation of BCL2. Lack of BCL2 allows cytochrome C to leak from the inner mitochondrial matrix into the cytoplasm and activate caspases. Okay, so energy. Apoptosis requires ATP to happen to function. Example of endometrial shedding during the menstrual cycle is an example of apoptosis. Removal of cells during embryogenesis is an example of apoptosis. Think of Hrithik Roshan's fingers. He has a double thumb. So Hrithik Roshan's fingers didn't have apoptosis happen, so that's why he has two thumbs. Okay, so people who have polydactyly, they had a failure of embryogenesis. So their apoptosis didn't happen properly during embryogenesis. Okay, so and then the third point is CD8 positive T cell mediated killing virally infected cells. Okay, so MHC class 1 will present antigen to CD8 positive T cell, and CD8 positive T cell kills virus through apoptosis. That's what that means. So MHC class 1 will present antigen to CD8 positive T cell. MHC class 1 will present antigen to CD8 positive T cell, and CD8 positive T cell kills virus through apoptosis. I'll show you that. CD8 positive T cell, and then MHC class 1. So CD8 positive T cell presents so this is the T cell, and this is the APC, antigen presenting cell. APCs can be macrophages or dendritic cells. They are the ones who always present the antigen. This red thing is a part of the APC that is known as MHC class 1. There's also MHC class 2, which is right here. But MHC class 1 is a part of the antigen presenting cell, and APCs can be macrophages or dendritic cells, and they are the ones who present a foreigner. This antigen right here is a microbe, is like some kind of microbe, presents that to the T cell to kill. This is the T cell receptor on the T cell, and the T cell receptor grabs the antigen to kill it. This is some kind of, it's not a microbe, it's a virus, because this is a CD8 positive T cell. It's a virus, or I think it can even be cancer cells. CD4, I believe, deals with microbes, but CD8 positive, they deal with viruses. So think of CD8, like there is a rule of 8. 1 times 8 is 8, 4 times 2 is 8. So MAC1 presents the antigen to CD8 positive T cell. 1 times 8 is 8. Think of it that way. And this deals with viruses. This one, MHC class 2, is on the APC, and that MHC class 2 presents the antigen to CD4 T cell. 2 times 4 is 8, and this deals with bacteria. Okay, so that is what that means. CD8 positive T cell is one of the ways apoptosis happens to get rid of viruses in our body. Okay, so that's there. Okay, so now what happens is the dying cell that apoptosis killed shrinks. leading to cytoplasm to become more eosinophilic. So the cytoplasm becomes very pink. Okay, I'll show you this. So the cytoplasms. Okay, this right here. This is a cell that apoptosis killed. You see how the cytoplasm around it is very pink? These other ones are normal. You see how they're all uniform and they're not pink? This is a cell undergoing apoptosis, and the cytoplasm is very pink. This center thing right here is his nucleus. Okay, so that's that. And then the nucleus condenses and fragments in an organized manner. So the nucleus will become small, very small. And if you look at that picture, the nucleus is shrinking. Next, the apoptotic bodies fall from the cell and are removed by macrophages. Apoptosis is not followed by inflammation. We went through that. Okay, so the apoptotic bodies, like the trash, is removed by macrophages. Next, apoptosis is mediated by caspases that activate proteases and endonucleases. What are proteases? There's something to break down protein. Proteins break down proteases break down the cytoskeleton, right? So remember this, caspases. That's like a high-yield topic, caspases. So caspases are seen in apoptosis. Apoptosis is mediated by caspases that activate proteases and endonucleases. So caspases activate proteases and endonucleases. Proteases are something that break down protein. And then, so the caspases activate proteases that break down the cytoskeleton, and then caspases also activate endonucleases that will break down the DNA. Okay. Next, how are caspases activated? They're activated in a few ways. The first one is intrinsic mitochondrial pathway. Here we have cellular injury, DNA damage, or decreased hormonal stimulation that leads to inactivation of BCL2. Lack of BCL2 allows cytochrome C to leak from the inner mitochondrial matrix into the cytoplasm and activate the caspases. Okay. So, cellular injury, DNA damage, or decreased hormonal stimulation leads to inactivation of BCL2. So, cellular injury, DNA damage, and decreased BCL2 all cause apoptosis. To happen, because if you damage DNA, or if you have the cell damage, this will lead to BCL2 not working, and if BCL2 is not working, that will cause the cytochrome C to leak out from the inner mitochondrial matrix into the cytoplasm of the cell, and that will activate the caspases. So the job of BCL2 is to stabilize mitochondrial membrane so cytochrome C cannot leak out of the mitochondria. Because once cytochrome C leaks out, that's going to activate caspases and cause apoptosis to happen. Okay, so what they're saying is this entire thing, is the yellow part, that's the cytoplasm of the cell. This blue thing is the mitochondria. Inside this blue thing, there's the cytochrome C outside, or maybe on the outer side of the mitochondria is the BCL2. BCL2 kind of keeps the cytochrome C very safe inside the mitochondria. But once there is damage to the cell, this will cause damage to the mitochondria, and this will make BCL2 not work. And if BCL2 is not working, it will cause the cytochrome C to leak out of the mitochondria into the cytoplasm and activate caspases, and that will activate apoptosis of the cell, and then the cell will be, the cytoplasm will become very pink, and the nucleus will shrink. That is apoptosis. So that's one way apoptosis happens, through action of a caspase. So, decreased BCL2 causes apoptosis to happen. Increased BCL2 stops apoptosis from happening. Remember that. Increased BCL2 stops apoptosis from happening. Decreased BCL2 causes apoptosis to happen. Okay, the second way that apoptosis happens through caspases is by so just a quick update. This is a fat necrosis, a peripancreatic adipose tissue. So this right here is the pancreas, and this is fat necrosis that's happening here. What are the two types of necrosis that happens to the pancreas? That was fat necrosis and liquefactive. So this is fat necrosis. Intravenous necrosis. This is the type of necrosis you will see in a malignant hypertension and in preeclampsia. And vasculitis. Okay. Next, we have the second way that apoptosis happens through caspases is extrinsic receptor ligand pathway. This is the Fas ligand. This is when Fas ligand binds Fas death receptor on the target cell, activating caspases. This is seen in negative selection of thymocytes in the thymus. Tumor necrosis factor binds TNF receptor on the target cell, activating caspases. Okay. What this means is something foreign binds a receptor on a cell, which then activates apoptosis. So I'll show you this. Okay, so the extrinsic receptor ligand pathway is when the Fas ligand binds the Fas death receptor on the target cell, activating caspases, and this is seen in negative selection of thymocytes in the thymus. So this is what this means. Fas ligand would be on the T cell, and Fas death receptor is on the target cell, whether that be a cancer cell or uh, a microbe. So this is what this is. So we have the T cell here, and we have a fast ligand here, right? Fast ligand is attached to the T cell, and that fast ligand binds with the fast receptor on the um, cancer cell, and then when that happens, caspases are activated, and this target cell dies. This cancer cell will die. So yeah, wherever the caspase, whichever cell the caspases are activated, that cell will die. Next we have tumor necrosis factor binds. We have the tumor necrosis factor binds a TNF receptor on the target cell, activating caspases. So TNF, which is tumor necrosis factor, is on the macrophage, and that will bind. See this. This macrophage has a. See this TNF? Do you see the TNF right here? This is on the macrophage. Well, I mean, it's produced by the macrophage, right? It's from the macrophage. So TNF alpha is produced from the macrophage, and that TNF alpha will bind the TNF receptor, which is on the tumor cell. The TNF receptor is on the tumor cell. So the TNF binds the TNF. So TNF on the macrophage will bind the TNF on the cancer cell, and that will activate caspases, and this will kill the caspases will kill the cancer cell. That's one of the ways our body regulates us from getting cancer. Our body keeps undergoing apoptosis so we don't get cancer. So our body is constantly producing random mutated cells, and our immune system, like the macrophages, our tumor suppressor genes, are all taking care of that. It's when we don't have access to this. Sorry, access. I just got like an email. So it's when we don't have we lose our tumor with the function of our tumor suppressor genes. We have decreased immunity, which means we are decreased macrophage. That is when cancer cells will take over, because apoptosis is not happening like it's supposed to. So that's that. And then next we have the third way that apoptosis happens is by cytotoxic CD8 positive T cell mediated pathway. Here, this one is the easiest one to remember. Here, the perforins are secreted by CD8 positive T cell. Perforins secreted by CD8 positive T cell create pores in the membrane of the target cell. Granzyme from CD8 positive T cell enters the pores and activates caspases. CD8 positive T cell killing of virally infected cells is an example. So what they're saying is CD8 positive T cell secretes perforins. Yeah, so this is an example picture right here. So this is the CD8 positive T cell right here. This CD8 positive T cell secretes perforins, and this perforins go to the target cell, and pokes holes in the target cell, killing the target cell. See this? Apoptosis. So that's how this cancer cell dies. This CD8 positive T cell kills this cancer cell through apoptosis, and they use the CD8 positive T cell uses the perforins to kill the cancer cell or a virus. This can be cancer or a virus. Okay? Alright. That's it for So that's it for that. Next we have free radical injury. Free radical injury. Free radicals are chemical species with an unpaired electron in their outer orbit. Physiologic generation of free radicals occurs during oxidative phosphorylation. Cytochrome C oxidase, like in complex 4, transfers electrons to oxygen. Partial reduction of oxygen yields superoxide, and then hydrogen peroxide, and hydrogen radicals. Pathologic generation of free radicals arises with ionizing radiation, water hydrolyzed to hydroxyl free radical, inflammation, and ADPH oxidase generates superoxide ions during oxygen-dependent killing by neutrophils. Metals, copper and iron. Iron generates hydroxyl free radicals, like in Fenton reaction. Drugs and chemicals. P450 system of liver metabolizes drugs. Acetaminophen, like in acetaminophen, generates the free radicals. Free radicals cause cellular injury by peroxidation of lipids and oxidation of DNA and proteins. DNA damage is implicated in aging and oncogenesis. Elimination of free radicals occurs by multiple mechanisms. The first one is antioxidants and glutathione vitamins A, C, and E. Enzymes, superoxide dismutase in the mitochondria. Superoxide, glutathione peroxidase in mitochondria, plus okay, so this free radical section, it was hard for me. I had to go through it again. So I'm going to read it again. So free radicals are chemical species with an unpaired electron in their outer orbit. Okay. So free radicals do not have a... Okay, free radicals are a species with an unpaired electron in their outer orbit. So this is a free radical. See this? This one. This is an unpaired electron in the outer orbit. See these other guys, they're all paired. Because this one is unpaired, there's an unpaired electron. That would make this a free radical. Okay. Okay. And then physiologic generation of free radicals occurs during oxidative phosphorylation. What is oxidative phosphorylation? It's how the body makes ATP. So if I can rephrase this, it will be physiologic generation of free radicals occurs when body makes ATP. So when the body makes ATP, you get free radicals. Cytochrome C oxidase, complex 4. Okay, so cytochrome C oxidase, also known as complex 4, transfers electrons to oxygen. So cytochrome C oxidase is in the inner mitochondrial membrane. That cytochrome C oxidase is also known as complex 4. This thing right here, this thing, transfers electrons to oxygen. So cytochrome C transfers electrons to oxygen. Partial reduction of oxygen yields superoxide, which is this, and then hydrogen peroxide, which is this, and then hydroxyl radicals, which is this. Okay. What does it mean to reduce oxygen? To reduce the oxygen means to add electrons to oxygen. So partial reduction of oxygen means to add electrons to oxygen. And when you add an electron to oxygen, I'll show you. So when you partially reduce the oxygen, um, oxygen becomes super oxide, and then superoxide becomes hydrogen peroxide, and hydrogen peroxide becomes hydroxyl radical. So um, you start with oxygen. See this? You start with oxygen, and you add an electron, and then you get the superoxide, and then you take the superoxide and add um, two electrons to it, and you get hydrogen peroxide. And then from hydrogen peroxide, you take the hydrogen peroxide, and then you add three electrons, and you get hydrogen radical. Okay, so that's what that is. Okay. Now, pathologic generation of free radicals arise with ionizing radiation, and inflammation, and from metals, and from drugs and chemicals. So the first one, how you get the free radical. Water is hydrolyzed into hydroxyl free radical. So H2O becomes the H2O becomes this, right? A hydroxyl radical. So that's one way to get it. Water becomes that. Then from inflammation, you can get free radical. NADPH oxidase generates superoxide ions during oxygen-dependent killing by neutrophils. Okay, so what happens is oxygen is taken by NADPH and converted into superoxide. Yeah, so oxygen is is taken by NADPH and converted into superoxide. So NADPH takes the oxygen and adds an electron, making it superoxide. Next, you can get from metals like copper and iron. Iron generates hydroxyl free radical, like in the Fenton reaction. So what's happening is that what happens is that when iron builds up, you get a disease known as um, hemochromatosis. The reason why hemochromatosis causes tissue damage is because iron makes hydroxyl free radicals. Wilson's disease is when there's a lot of copper in your body, and that also generates the free radicals. That's how copper and iron generate free radicals. Drugs and chemicals also generate free radicals. The P450 system of the liver metabolizes drugs like acetaminophen, generating free radicals. That's why if you take too much acetaminophen, it's a hepatotoxic. So yes. So acetaminophen goes to the liver and gets converted by P450 system, and then free radicals are made in the process. Increased dose acetaminophen causes massive liver necrosis due to hepatocytes generating free radicals. Okay. Um, yes, that's that. And free radicals cause cellular injury by peroxidation of lipids and oxidation of DNA and proteins. DNA damage is implicated in aging and oncogenesis. So free radicals cause cellular injury by peroxidation of lipids. What does that mean? Peroxidation of lipids means the lipid cell membrane is damaged, and oxidation of DNA is a type of DNA damage. So free radicals cause injury to the cell by um, damaging the cell membrane of the lipids in the cell, and by damaging the DNA in the cell. And it also damages, free radicals also damage the proteins in the cell. And this is what happens when we age and also in cancer formation. So next we have elimination of free radicals. This is how the body eliminates the free radicals. Um, the body eliminates free radicals by a few mechanisms. The first is antioxidants, then you have enzymes, uh, then you have metal carrier proteins. So the very first one, antioxidants, um, you uh, um, the antioxidants here are glutathione and vitamins A, vitamin C, and vitamin E. The next one, how the body eliminates the free radicals, is by enzymes, specifically superoxide dismutase, which is in the mitochondria, and then glutathione peroxidase, which is also in the mitochondria. Then you have catalase, which is in the peroxisomes. So each of these ones, we're going to start with superoxide dismutase. What happens here is that superoxide. Remember we talked about superoxide right here? This is superoxide. Superoxide gets converted to hydrogen peroxide, by something known as superoxide dismutase, and you get water. I guess what they mean is you get water in the end product. Let's see, because the thing is, H2 hydrogen peroxide, that's still a free radical. So what they're saying is superoxide is converted by superoxide dismutase into hydrogen peroxide, and then you see the same hydrogen peroxide in the last step. The hydrogen peroxide is converted to oxygen and water by catalase. So in the end, you get the water and oxygen. So the body is rid of free radicals. So the superoxide itself is a free radical. H2O2 is not a free radical. I said it was earlier, and that's a mistake. It's not. Hydrogen peroxide is not a free radical, but it can form free radicals. So what the body does is that it takes this hydrogen peroxide and then um, catalase. So catalase takes this hydrogen peroxide and makes water and oxygen out of it. So the body is rid of free radicals. So superoxide dismutase, what happens is superoxide gets converted to hydrogen peroxide by superoxide dismutase, and then the second it's not, I don't know if it's the second step, but the second way that the body gets rid of free radicals is that the glutathione peroxidase in the mitochondria converts the reduced glutathione and free radical, right? Free radical into oxidized glutathione and water. So you see this free radical right here? Glutathione peroxidase comes and gets to get rid of this. The goal of glutathione peroxidase is to get rid of the free radical so that glutathione peroxidase can make the oxidized glutathione and water. See how the reduced glutathione, this is reduced glutathione. The oxidized glutathione and water is not toxic to the body, and water and oxygen is not toxic to the body. So yeah, catalase is good for the body because it gets rid of hydrogen peroxide and makes the water and oxygen in the body. So this entire step was confusing. I hate this chapter with a passion. Okay, but it's okay. You know, I was never good at chemistry. It drove me nuts. It drove me absolutely crazy. But yes. So that's what you have to do. Me too. So one thing you have to know is that free radicals cause cell injury by peroxidation of lipids and oxidation of DNA and proteins. The body gets rid of free radicals by antioxidants, like vitamin A, C, and E. Metal carrier proteins. These metal carrier proteins hide away metal, so free radicals are not generated. So this one right here, metal carrier proteins, transferrin and ceruloplasmin, hide away metal, so the free radicals are not generated. Remember how we say how we said like copper? So copper is a metal, and so to protect our body from building up, copper, the metal carrier proteins like transferrin and ceruloplasmin um, hide they hide the metal, so free radicals are not generated. Enzymes eliminate free radicals also. So superoxide free radical is handled by superoxide dismutase. Hydrogen peroxide is handled by catalase, and then hydrogen free radical is handled by glutathione peroxidase. So I just realized the dot in hydroxyl free radical, this right here, this dot, this dot, this dot, that they all represent unpaired electrons in the outer orbit. So this is superoxide. This is superoxide, and this is hydroxyl free radical. Um, those three are the free radicals. The rest, like hydrogen peroxide and oxygen, they can make free radicals. I just learned that right now. Okay. Next, we have examples of free radical injury. So, examples of free radical injury: carbon tetrachloride, also known as CCl4. This is an organic solvent used in the dry cleaning industry. It's converted to CCl3 free radical by P450 system of hepatocytes, results in cell injury with swelling of rough ER. Consequently, ribosomes detach, impairing protein synthesis. And there is decreased apolipoproteins that lead to fatty acid change in the liver. Okay, reperfusion injury. Return of blood to ischemic tissue results in production of oxygen-derived free radicals, which further damage tissue. This leads to a continued rise in cardiac enzymes like troponin after reperfusion of infarcted myocardial tissue. So, the function of the liver is to gather fat from the diet and repackage it and send it back out. So that's a function of the liver. It's to gather fat from the diet and repackage it and send it back out of the liver. So in CCL3 injury, if the liver is damaged, you will have lack of apolipoprotein, This means there will be increased fat that stays in the liver. Okay, so in CCL3 injury, because the liver is damaged, in CCL3 the liver is damaged because there's swelling. Um, there's swelling in the liver. The ribosomes pop off, and you can't do protein synthesis. And if you can't do protein synthesis, you're going to have decreased apolipoproteins in the liver, and this will cause fatty change in the liver. And so there's increased fat in the liver cells, and fat can't leave the liver. You have lack of apolipoproteins in the liver, due to decreased protein synthesis in the liver from the CCL3 injury. This means there's increased fat that stays in the liver, so the fat that the body needs the body won't receive from the liver in CCL3 injury. So to recap, right? So to recap, uh, carbon tetrachloride, which is CCl3, is a solvent used in the dry cleaning industry. Now, that solvent, that CCl4, can be converted to CCl3 by the P450 system in the liver. And when that happens, CCl3, which is toxic to the liver, when that happens, you get swelling of the rough ER in the liver. When you get swelling of the rough ER in the liver, the rough ER, the ribosomes on the rough ER pop off, and if the ribosomes pop off, you can't do protein synthesis anymore. And if you can't do protein synthesis, you can't make apolipoproteins, which are proteins of the liver. And the job of the liver, so the job of apolipoproteins is to help lipoproteins move fat around the body and get into the cell. So it's to apolipoprotein helps move fat around the body and get into the cells of the body. And if you don't have apolipoproteins, you can't get fat into the cells of the body. Therefore, apolipoproteins are defected, and this causes fat to build up in the liver itself. And so, in CCL3 injury, you will see increased fat in the liver. Yes, that's right. So now you have reperfusion injury. This is the return of blood to ischemic tissue um, that results in production of oxygen-derived free radicals, which further damage the tissue. This leads to a continued rise in cardiac enzymes like troponin after reperfusion of infarcted myocardial tissue. So this is when blood and oxygen and inflammatory cells rush back into the artery after an MI, causing free radicals. So the reason that there's free radicals is because blood has oxygen, and oxygen produces free radicals, which will cause increased troponin after blood rushes back into the ischemic area. So, blood has oxygen, and oxygen produces free radicals. Remember the um, superoxide dismutase kills oxygen. So superoxide is a free radical, right? That's when so superoxide, right? Remember that chart that we were talking about? Um, Oxygen uh, to super oxide to hydrogen peroxide to hydrogen free radical that causes water to form. Yeah. So remember we talked about if to reduce oxygen means to add electrons to oxygen. So when you add an electron to oxygen, you get superoxide. Yeah, you get superoxide. And if oxygen accepts two electrons, uh, that's when you get the hydrogen peroxide. And if oxygen accepts three electrons, it's when you get the hydrogen radical. Hydroxyl radical, my goodness. Hydroxyl radical. Then it becomes water. So this is to prevent free radicals in the body. So superoxide um, and hydrogen free radical. Okay, so yeah, so superoxide and hydroxyl free radical are both free radicals that come from oxygen. So those free radicals will be increased after an MI. That will be superoxide um, and hydroxyl free radical. So yes, you're going to have an increase in superoxide and an increase in hydrogen and an increase in hydroxyl free radical. Both of these increase in superoxide and increase in hydroxyl free radical in reperfusion injury, which is when blood rushes back into um, an ischemic tissue. Let's say, for example, after an MI, and this will cause increase in free radicals. Okay. Next, you have amyloidosis. Okay, so amyloidosis. The amyloid is a misfolded protein that deposits in the extracellular space, means outside of the cell. Amyloid deposits outside of the cell, um, thereby damaging tissues. Multiple proteins can deposit as amyloid. Shared features include beta-plated sheet configuration, Congo red staining, and apple green birefringence when viewed microscopically under polarized light. Deposition can be systemic or localized. Amyloid is a what? Misfolded protein. Deposits where? Outside of the cell. Amyloid deposits in extracellular space, and this damages tissue. Multiple proteins can deposit as amyloid. Shared features include beta-plated sheet configuration and amyloid stains Congo red So Congo red stain is a type of stain, which is used to detect the amyloid in the tissue. So Congo red is a type of stain that can identify the amyloid in the tissue. Or doctors use polarized light, which is a type of light that helps doctors see the amyloid better. Okay. Systemic amyloidosis. Amyloid deposition in multiple organs. This is divided into primary and secondary amyloidosis. Primary amyloidosis is systemic deposition of AL amyloid, which is derived from immunoglobulin light chain associated with plasma cell dyscrasias. Secondary amyloidosis is systemic deposition of AA amyloid, which is derived from serum amyloid associated protein. SAA is an acute phase reactant that is increased in chronic inflammatory states, malignancy, and familial Mediterranean fever. Familial Mediterranean fever is due to a dysfunction of neutrophils, which is autosomal recessive and occurs in persons of Mediterranean origin. This presents with episodes of fever and acute serosal inflammation, can mimic appendicitis, arthritis, or MI. High serum amyloid associated protein during attacks deposits as AA amyloid in tissues. Clinical findings of systemic amyloidosis are diverse since almost any tissue can be involved. Classic findings include nephrotic syndrome. Kidney is the most common organ involved. You can also see the restrictive cardiomyopathy or arrhythmia. Number 3, you will see tongue enlargement, malabsorption, and hepatosplenomegaly. Okay, amyloidosis diagnosis requires tissue biopsy. You will see abdominal fat pad and that the rectum are easily accessible biopsy targets. Damaged organs must be transplanted. Amyloid cannot be removed. So amyloid deposits in multiple tissues. So it can deposit in your heart, in your lungs, your kidney, anywhere. Amyloid is divided into primary and secondary amyloidosis. The primary amyloidosis is a systemic deposition of AL amyloid. AL amyloid is derived from Ig light chain. Remember what light chain is? I'll show. Let's see. Oh my goodness. So this right here, this is light chain. This part is light chain, and this part is FC portion. So this right here is the light chain, and that is where, like from this part, that is where you get AL amyloid, right? AL amyloid. That's AL amyloid is what is deposited in primary amyloidosis. This AL amyloid is associated with plasma cell dyscrasias, which is seen in multiple myeloma. So in plasma cell dyscrasias, there can be overproduction of light chain, and overproduced light chain will leak out into the blood, and light chain can become misfolded, and this is how you get the primary amyloidosis. I'm going to repeat that. In plasma cell dyscrasias, there can be overproduced light chain. There can be overproduced light chain, and overproduced light chain will leak out into the blood, and light chain can become misfolded, and you get primary amyloidosis. Okay, so in multiple myeloma, you have an excess of plasma cells, and you also have excess of light chain from the Ig. And this light chain leaks out into the blood, and becomes misfolded, which is what amyloid is. It's misfolded protein. Okay. So next, secondary amyloidosis is systemic deposition of AA amyloid. Yes, so secondary amyloidosis is a systemic deposition of AA amyloid, which is derived from serum amyloid associated protein. So in secondary amyloidosis, this is a deposition of AA amyloid. And AA amyloid is derived from serum amyloid associated protein. So AA amyloid is derived from serum amyloid associated protein. Serum amyloid associated protein is an acute phase reactant. When there is inflammation, there is an increase in serum amyloid associated protein, and serum amyloid associated protein can be converted to AA amyloid, and this AA amyloid can deposit in tissues, creating amyloidosis. Okay. Yeah. And then systemic deposition, AA amyloid. Derived from So SAA, serum amyloid associated protein, is an acute phase reactant. And when there is an inflammation, there is an increase in serum amyloid associated protein, and serum amyloid associated protein can be converted to AA amyloid, and this AA amyloid can deposit in tissues, creating amyloidosis. And serum amyloid associated protein is an acute phase reactant that is increased in chronic inflammatory states, like autoimmune diseases, cancer, and familial Mediterranean fever. Familial Mediterranean fever is due to a dysfunction of neutrophils and occurs in people of Mediterranean origin. So people with this familial Mediterranean fever present with episodes of fever and acute serosal inflammation. It can look like appendicitis, arthritis, or heart attack. And high serum amyloid associated protein during attacks deposits high serum amyloid associated protein during attacks deposits as AA amyloid in tissues. Okay, so yeah, so this Mediterranean fever, this presents as fever and acute serosal inflammation that can look like appendicitis, arthritis, or heart attack. High serum amyloid associated protein during these attacks in the familiar Mediterranean fever, um, because it's fever. There's inflammation, and there's inflammation in the body. So if there's inflammation, you're going to have an increase in serum amyloid associated protein. And this serum amyloid associated protein gets converted to AA amyloid, and this AA amyloid, it deposits in the tissues, causing the secondary amyloidosis. Classic findings of systemic amyloidosis are diverse, since almost any tissue can be involved. Classic findings include nephrotic syndrome. Kidney is the most common organ involved, and what you see is nephrotic syndrome, which is when there is an increase in protein in the urine. And you also see restrictive cardiomyopathy or arrhythmia, so the heart cannot pump as efficiently, so there's less cardiac output in somebody with amyloidosis. Number 3, you see tongue enlargement, malabsorption, and hepatosplenomegaly. So you see the liver is enlarged, the spleen is enlarged, all due to the deposition of amyloid, right? So something's getting added on, so of course it's going to be bigger. That makes sense, right? Yeah. Diagnosis requires tissue biopsy. Abdominal, fat pad, and rectum are easily accessible biopsy targets. Damaged organs must be transplanted. Amyloid cannot be removed. Okay, next. So this right here, this metal pitcher is the Congo red stain that's used to identify the amyloid, and this is under polarized light. This is the amyloid under polarized light. It looks green. Okay, and this right here is from a previous lecture, how we talked about apolipoproteins, how the liver has a decrease in apolipoproteins due to the CCL3 injury. And here you see the fatty change, this globule fat, this fatty change in the liver. Okay, now we're going to localized amyloidosis. This is when the amyloid deposition usually localized to a single organ. Amyloid deposition usually localized to a single organ. Senile cardiac amyloidosis, non-mutated serum transthyretin deposits in the heart, usually asymptomatic, present in 20% of individuals over 80 years of age. Familial amyloid cardiomyopathy. Okay. So localized amyloidosis means that amyloid deposits are in one organ. Um, senile cardiac amyloidosis is non-mutated serum transrethrin deposits in the heart. So, which means that serum transrethrin deposits in the heart of old people. So, serum transrethrin deposits in the heart of old people. This is usually asymptomatic. This is seen in 25% of individuals over 80 years of age. So, it's an elderly people disease. The senile cardiac amyloidosis. Next, familial amyloid cardiomyopathy. This is when you see mutated, right? Because before, in the senile, cardiac amyloidosis, the transrethrin was not mutated, but in familial amyloid cardiomyopathy, it is mutated serum transrethrin. Yeah, so right here, in the familial amyloid cardiomyopathy, it is mutated serum transrethrin deposits in the heart, leading to a restrictive cardiomyopathy. 5% of African Americans carry this mutated gene. So, okay, so in the old people amyloidosis, it is not mutated, right? That, think of it as like with old age comes a lot of problems. You can even get amyloidosis, right? It is not due to a hereditary problem. It's something that happens with old age, I would say, because it's not mutated. But this one, in the familial amyloid cardiomyopathy, it is the problem is because there is a mutation, mutated serum transrethrin, mutated serum transrethrin. I can't say that word. Mutated serum transrethrin deposits in the heart, causing a restrictive cardiomyopathy, which means the heart cannot fill and it can't pump properly either. So, what you have to know is that amyloidosis causes a restrictive cardiomyopathy. Okay. Next, non-insulin dependent diabetes mellitus. Type 2. Amylin, which is derived from insulin, deposits in the islets of the pancreas. Okay, so amylin is a byproduct of excess insulin, and amylin deposits in the islets of pancreas in type 2 diabetes mellitus. Okay, yeah, that's a pancreas problem due to amylin. Alzheimer's. Alzheimer's is when there's AB amyloid, which is derived from the beta amyloid precursor protein, and this AB amyloid deposits in the brain, forming amyloid plaques. The gene for beta APP is present on chromosome 21. Most individuals with Down syndrome, which is trisomy 21, which is 3 copies of 21, develop Alzheimer's disease by the age of 40. So that they will have early onset Alzheimer's. Okay. So what you have to know about Alzheimer's is that this AB amyloid is derived from beta amyloid precursor protein, and AB amyloid deposits in the brain. And chromosome 21 has beta amyloid precursor protein on chromosome 21. Chromosome 21 has beta amyloid precursor protein on chromosome 21, so Down syndrome patients get Alzheimer's by age 40. So this beta amyloid precursor protein is on chromosome 21. And chromosome 21 has the beta amyloid precursor protein on the chromosome 21. So Down syndrome patients get the Alzheimer's by age 40. Okay, so the Down syndrome patients have 3 copies of chromosome 21, and on this chromosome 21 is where this beta amyloid precursor protein is located. And AB amyloid, which is the problem in Alzheimer's, is derived from this beta amyloid precursor protein that is located in chromosome 21. Okay, next. Dialysis associated amyloidosis. Beta 2 microglobulin deposits in the joints. Okay. This beta 2 microglobulin is a part of MHC1. So beta 2 microglobulin is a component of MHC class 1, and beta 2 microglobulin deposits in the joints, mainly dialysis patients. Okay. So dialysis-associated amyloidosis is when the beta 2 microglobulin deposits in the joints, and that is derived from this beta 2 microglobulin is derived from MHC class 1. Next one. Medullary carcinoma of the thyroid. Calcitonin produced by the tumor cells deposits within the tumor cells in an amyloid background. So medullary carcinoma of the thyroid is a tumor of the thyroid that's derived from C cells. C cells produce calcitonin, and increased calcitonin deposits in the tumor. So medullary carcinoma of the thyroid is cancer. You have increased calcitonin in this type of cancer. Tumor of thyroid. That's Yeah, so in this type of cancer, there is an increase in C cells. C cells produce calcitonin, and increased calcitonin deposits in the tumor. And you see tumor cells in an amyloid background. The thyroid is biopsied by fine needle aspiration, and the doctor sees tumor cells in an amyloid background. This is medullary carcinoma of the thyroid. And with that, we are done. Chapter 1.